Hello, everyone. This chapter is about anti-Parkinson drugs. In some textbooks, it is also named by drugs for neurodegenerative disease. Neurodegenerative disease are characterized by the progressive loss of selective neurons in discrete brain areas. This disease can be characterized by disorders of movement, cognition, or both. And the signs and the symptoms of neurodegenerative disease do not reflect a normal age-related loss of brain neurons. Instead, these progressive disease states are the result of an underlying pathologic process. This neurodegenerative disease include Parkinson's disease. It also it can be described by PD. Alzheimer's disease, the abbreviation is AD. Multiple sclerosis, MS. Amyotrophic lateral sclerosis, ALS. The PD and AD, only these two degenerative diseases are related to the age. Usually, the case rate in the elderly people is relatively higher. And the multiple sclerosis and ALS, these two degenerative diseases also occur in the young people. Although the cause of this disease is unknown, the evidence suggests that these diseases are related to heredity, autoimmunity, and environmental factors. But the function of our seeing eyes is so secret. So far, only there are 3 hypotheses partly explain the mechanism of the disease. They include excitotoxicity, apoptosis, oxidative stress. The substantial progress has been made in the development of drugs to treat PD and somewhat for AD. However, drug therapy for the other degenerative disease is very limited. That's why in this chapter, we mainly study Parkinson's disease drug, because only this disease, the patients with PD, can be treated by some drugs, but actually these drugs just inhibit the development of this disease, just improve the symptoms. Actually, because of this neurodegenerative disease, the life quality of the patients are largely reduced. Only the drugs in the treatment of PD can largely improve the patient's life quality, and a little improvement in the treatment of AD. So that's why in this chapter we mainly study the drugs for PD. This disease, it was first described by an Englishman named Parkinson. So that's why it's caused by Parkinson's disease. But actually, it also has another medical term to describe this disease: paralysis agitans. Parkinsonism, it is a progressive neurological disorder of muscle movement. It can be characterized by resting tremor, muscular rigidity, bradykinesia, and ataxia. Actually, these all typical symptoms of PD are because increased muscular tension. Resting tremor, especially the patient's hand always in this posture. And especially when the patients are in resting, this hand usually has a little rapid rubbling pulse tremor. It is 4 to 6 Hz, especially when the patients are nervous. And in resting, this tremor is more obvious. After sleep, of course, this tremor will disappear. Because of increased muscular tension, the expression on the face is reduced. So the patient usually has this expression of the face. We usually call this is mask face. Expression of the face, skeletal muscle in face. It is very nice. So it seems like a mask face. And because of the advantage of flexor grooves, so usually the patient has a special posture, rocking body forward like this. And because of muscular rigidity, the patient has a problem to initiate or carry out voluntary movement. So it's bradykinesia. And because of increased muscular tension, to finish some fine motor manipulation is so difficult for the patients with PD. So here I have a video. I'm sorry. Well, it cannot work. Later, I will insert this video. Okay. I will insert this video in the PPTs because this app doesn't work with this video. Okay, let's go on. Just now I mentioned actually the cause of this PD is largely unknown. In most cases, heredity appears to have a limited role. And till now, it is discovered the diseased region in the patients with PD is in substantia nigra. Now, for the normal people, means the people without PD, this area in the brain tissue, its color is black. But for the patients with PD, it is not black anymore. It's because of atrophy of substantia nigra. In 1953, it was confirmed the local area of the disease in substantia nigra on the corpus stratum. And in about 1960, it was discovered that patients with PD, the dopaminergic neurons in substantia nigra, was reduced. So there is an imbalance between the substantia nigra corpus stratum pathway, and it often means there is an imbalance between dopamine and acetylcholine neurotransmitter pathways. So here, based on this dopamine theory, it mostly explained why some drugs are effective in the treatment of PD and why the patient has some symptoms related to this substantia nigra pathway. Now look at it. In the normal state, normal people, substantia nigra, there are some dopaminergic neurons can generate dopamine and release dopamine as a neurotransmitter. And this neurotransmitter acts on the spinal motor neurons. It has inhibitory effect. So This inhibitory effect on the spinal motor neurons, it decreased the muscular tension. But in the caudatum, it also have some cholinergic neurons can generate and release acetylcholine as another neurotransmitter in the seeing eyes. Based on activation of M receptor, these cholinergic nerves act on the spinal motor neurons. It has a stimulant effect. So the result is increased muscular tension. So for the normal state, this dopaminergic pathway and cholinergic pathway, they are in imbalance in the regulation of the tension of muscle coordination. So we can finish many voluntary movements. So the muscular tension is in normal state. But for the patients with PD, the problem is in substantia nigra. Maybe the neurons in this area, it is damaged by some pathological process, or maybe has in later. So the synthesis or release of this neurotransmitter dopamine, it is not enough. So this inhibitory effect on the spinal motor neurons, it also is not enough. So the cholinergic neurons act on the spinal motor neurons. They don't predominate. So muscular tension increased. This result is muscular tension increased because of cholinergic function predominate. So the patient has some symptoms related to increased muscular tension, tremor, muscle rigidity, bradykinesia, and ataxia. So here, I think you can understand the problem is in substantia nigra because the neurons synthesis and release dopamine, this neurotransmitter, is not enough. So here you can understand the drugs, if they can increase the dopaminergic function, so increase the inhibitory effect on the spinal motor neurons, it can recover this balance. Of course, on the other hand, anticholinergic drugs, they can inhibit the cholinergic neurons, decrease the stimulant effect by these cholinergic neurons on the spinal motor neurons, try to decrease the muscular tension. It also is effective to correct this imbalance between these two pathways. Are you clear now? So here, maybe you are wondering, what drugs are anti-Parkinson drugs? Why they can be used to treat PD? Welcome you back. Because of degeneration of the patients with PD in substantia nigra, dopaminergic neurons have learned the neurotransmitter of dopamine are not enough. So there is an imbalance between dopaminergic neurons and cholinergic neurons pathways. So muscular tension increased. The patients show some symptoms like tremor, muscular rigidity, and bradykinesia. So the drugs, most currently available drugs, aimed to maintain CNS dopamine levels as constant as possible. These agents offer temporary relief from the symptoms of the disorder, but they do not arrest and reverse the neural degeneration caused by the disease. So there are many drugs just to mimic the dopaminergic function. They include precursor of dopamine, Lavadopa. There are some agents, Lavadopa synergist, like peripheral ADC inhibitor carbidopa. And the two metabolism enzymes for dopamine include AOB and COMT. So they are inhibitors like selagelin and naticapone. And there are some drugs can directly activate dopamine receptor. So they called by dopamine receptor agonist, bromocriptine and pergolide. And also there are some agents like amantadine can promote the release of dopamine from the neurons. So these drugs are dopaminergic drugs. They mainly increase the function of dopamine neurons, try to recover that balance. And one of the better known theory for the cause of PD, it is caused by oxidative stress theory. So according to this theory, metabolic oxidation of dopamine in the basal ganglia cause highly reactive free radicals that are toxic to dopaminergic neurons and lead to their degeneration. So scavenger of oxygen-free radical like selagelin, it also is effective in the treatment of PD. And this imbalance is also related to cholinergic pathway in the substantia nigra stratum corpus. Yeah, so anticholinergic agents like trihexyphenidyl, it also is effective in the control of the symptoms of PD. Let's study one by one. First one, Lavadopa. Lavadopa, it is a precursor of dopamine. Yeah, maybe someone want to ask, because dopamine is not enough as a neurotransmitter in seeing us, why we don't use dopamine directly? Yeah, the answer because is dopamine cannot pass across BBB, blood-brain barrier, remember? You have studied. Dopamine, it is one of catecholamines like epinephrine, norepinephrine, and isoproterenol. Dopamine also is one catecholamines. Because of their specific structure, they cannot pass across blood-brain barrier. So when we administer directly dopamine, it just acts on the peripheral tissue. In the treatment of PD, the problems of seeing us, it is invalid. So that's why we just use Lavadopa. Because Lavadopa, after oral administration, about 1 to 3% of Lavadopa amount of administration can pass across blood-brain barrier. And then in the brain tissue, based on amino acid decarboxylase, AADC. This enzyme name is AADC. Dopamine, Lavadopa in the brain tissue or in the peripheral tissue, they also based on this, depending on this AADC, convert into dopamine. So this dopamine supply dopamine for the substantia nigra and recover the balance between dopamine and acetylcholine. So this is the pharmacological effect of Lavadopa on the treatment of PD. But here you can understand, only 1 to 3% of the amount administered of Lavadopa can be effective in the treatment of PD, because only this amount of drug can pass across BBB. So more than 90% of the Lavadopa act on the peripheral tissue. And after oral administration, actually, about 70% of the amount administered metabolized in the GI tract, but more than 20%, almost 30%, convert into dopamine in the peripheral tissue. So act on the peripheral tissue. They just induce some adverse effects, even toxicity. Only 1 to 3% pass across BBB, so they are effective. When we use the Lavadopa alone, so only 1 to 3% are useful. So there is another drug named by Carbidopa. It can work as a Lavadopa synergist. This is ADC inhibitor. This is very important enzyme for the formation of Lavadopa, for the conversion from Lavadopa to deep dopamine, But, Carbidopa, this drug, cannot pass across blood-brain barrier. It just inhibits the ADC in the peripheral tissue. So, actually, it is just a drug for adjunctive therapy of PD. If it is alone Carbidopa, it is invalid to use in the treatment of PD. When Carbidopa used in combination with Lavadopa, it can inhibit ADC in the peripheral tissue. And there are more Lavadopa in the peripheral tissue stay at Lavadopa, not convert into Lavadopa, dopamine. So there are more Lavadopa pass across BBB. Maybe the total amount is about 10% of the amount of administration. So the final result, when Lavadopa is used in combination with Carbidopa, if the dose of administration of Lavadopa is the same as it used alone, about 10% of Lavadopa can pass across blood-brain barrier. So the final result is it can increase therapeutic effects. And in the peripheral tissue, dopamine is also reduced by Carbidopa. So the adverse effects is reduced. So that's why these two agents usually they used in combination. Are you clear now? Yeah. So there is a question. Why in the treatment of PD, why Lavadopa usually used in combination with Carbidopa? Can you explain? Yeah. To answer this question, you should first answer when Lavadopa used alone. What is its result? And then you also need to explain what is Carbidopa. ADC inhibitor cannot pass across BBB, only act on the peripheral tissue, inhibit this conversion from Lavadopa to Lavadopa, so increase the percentage of Lavadopa to pass across BBB. So the final result is increase therapeutic effects and decrease adverse effects. Are you clear? Okay. But the patients with PD, because of increased muscular tension, it often exhibits some symptoms. But actually, in the treatment by Lavadopa, for the different people to improve different symptoms, it has different curative effect. Usually, for PD originated either from a primary or secondary, some patients show some symptoms like PD. They are not degenerative disease in seeing eyes, maybe caused by some drugs like phencyclidine. This drug, it is one antipsychotic drug in the treatment of schizophrenia. Maybe some patients will show some adverse effect like PD. This is secondary PD, not a primary PD. So for this PD caused by phenothiazide, Lavadopa is invalid because this drug, phenothiazide, can block dopamine receptor. Although you increase dopamine supply by Lavadopa, because the receptor is blocked by phenothiazide, so Lavadopa and dopamine, they cannot work. Are you clear? So, but if the secondary PD caused by some other cause, like trauma in the brain tissue, like a tumor in the brain tissue, this also is useful. Only for the secondary PD caused by this drug, dopamine receptor blockers, it is invalid. But others, primary PD or secondary PD caused by some other cause, it is effective. To improve symptoms, Lavadopa can improve muscular rigidity and bradykinesia. To improve these symptoms, it's better than to improve muscular tremor. And the therapeutic effect also is related to latent extent of substantial nigra corpus stratum. And because of aging, this disease it also develops. So the therapeutic effects is also related to dosage and course of treatment. Usually, the patients, if the patient is relatively young, or the latent extent of substantial nigra corpus stratum is relatively slight, not very serious, the therapeutic effect is better. And it also is related to dose and course of treatment. It also partly because of the development of the disease in the patient's body. And it also because of long-term therapy by Lavadopa. Patients typically experience a decline in response during the 3rd to 5th year of therapy. So in early disease, the number of residual dopaminergic neurons in the substantia nigra is adequate for conversion of Lavadopa to dopamine. So in new patients, the therapeutic response to Lavadopa is relatively consistent, and the patients rarely complains that the drug effects wear off. Unfortunately, with time, the number of neurons decreases, just now I mentioned, because of the further development of this disease. Fewer cells are capable of converting exogenously administered Lavadopa to dopamine. So as the result, motor control fluctuate developments. So the therapeutic effects is not expected with the course of treatment. So here, maybe you still are wondering, what are the adverse effects of Lavadopa? How to deal with these adverse reactions? Let's go on. Adverse reactions of Lavadopa and carbidopa in the treatment of PD. It usually include peripheral effects and the CNS effects. The peripheral effects, these are usually early reactions induced by dopamine in peripheral tissue. After oral administration of Lavadopa, although it is used in combination with carbidopa, mostly in the peripheral tissue. Most percentage convert into dopamine in peripheral tissue. So in the peripheral tissue, we also have dopamine receptor, and dopamine also can activate beta 1, even alpha receptor. Remember that? Okay, so act on the peripheral tissue. In the GI tract, more than 80% of the patients treated by Lavadopa will show some symptoms of GI tract like nausea and vomit, because dopamine also can stimulate the dopamine receptor in CTZ. Do you know what is CTZ? Chemoreceptor trigger zone. This CTZ is the abbreviation of chemoreceptor trigger zone. Here, this zone also have dopamine 2 receptor. Once it is activated by dopamine, it usually involves vomit, even nausea and vomit. Act on the CVS, cardiovascular system, because dopamine can activate dopamine receptor, beta 1 receptor, even a little alpha receptor. But because of activation of dopamine receptor, it induces vasodilation. Remember that? Vasodilation. So maybe induce postural hypotension. A little wrong this. And act on the cardiac cells. It induces tachycardia because of activation of beta 1 receptor. These reactions occurs early in the treatment therapy by Lavadopa. But there are some symptoms from CNS effects. These reactions caused by long-term therapy. It include dyskinesia. It also caused by hyperkinesia. After 2 years of therapy, about 90% of patients treated by Lavadopa will show hyperkinesia. And this hyperkinesia, from this term, maybe you can understand, it is opposite to bradykinesia. It's usually caused by overexcitation of the dopamine receptor by activation of dopamine. So the patients will show some abdominal involuntary movements. Like the patients will show some incoordination of the muscular cell, skeletal muscle in the face to express the expression of the face. And the forelimbus maybe show some abdominal involuntary movements. So it related to the overexcitation of dopamine receptor in the seeing eyes. So you can understand dopamine receptor antagonist maybe is effective to control this hyperkinesia. Fluctuation, it also caused by on-off response. After 3 to 5 years treated by Lavadopa, about 40 to 50% of the patients will show these symptoms. Fluctuation. And some patients, about 10 to 15% of the patients treated by Lavadopa show mental confusion. It also caused by behavior effects. Now, just now I explained, because of the dopamine receptor overexcited by dopamine, exogenous dopamine, it shows some symptoms of abdominal involuntary movements in hand, foot, even the whole body. So the antagonist of dopamine receptor, lavadopa, maybe it is effective to control this hyperkinesia. And some patients will show fluctuation. It also caused by on-off phenomenon. It means the therapeutic effect caused by Lavadopa. Sometimes it is good. Sometimes it's not good. So when it is on, it means the patients will show normal action. It is caused by effective drugs. Sometimes the PD symptoms become unexpectedly severe. It means during that period, the drugs, Lavadopa, doesn't work. About 40 to 80% of the patients treated by Lavadopa, they will show this fluctuation adverse effect in 3 to 5 years. The mechanism of this fluctuation is related to the storage of dopaminergic neurons reduced. So the symptoms of improvement totally relies on the drug intake. So for the repeated dose, repeated administration, the drug concentration in plasma fluctuate between the two levels. Remember that? So when the concentration of the dopamine in the body, it is enough to maintain the symptoms, to maintain the control of the symptoms, it will show as on phenomenon, normal state. When the concentration of the drug in plasma is not enough to control, so maybe it is off phenomenon. So to control this fluctuation, we can use some drugs like bromocriptine or salicylic. These also can use to treat PD. Maybe depending on adjusting medication, it also is effective. This is also related to the development of the disease. It is neurodegenerative disease. With the aging, with the further lesion of the dopaminergic neurons by this disease degeneration, the storage of dopamine in the body, it is not enough. About 10 to 15% of the patients will show behaviors effects because dopamine also acts on limbic symptoms. The patients will show some symptoms like schizophrenia, mental illness. It is abnormal. Maybe just because of these behaviors effects, some drugs cannot use, or some patients cannot use Lavadopa to treat. To control this behaviors effects caused by Lavadopa. Clozapine, it also is one antipsychotic drug. Maybe it is effective to correct. So although Lavadopa used in combination with carbidopa, they are effective in the treatment of PD. But, no one agents can inhibit this development of the disease. So, with the time goes by, with time going, the therapeutic effect is not enough. And during the therapy, because some drugs also affect the curative effects by Lavadopa, the patients also need to pay more attention about these drug interactions. Pay attention to these drug interactions, like vitamin B6. This vitamin B6, it is ADC's procytic group. So it can increase the peripheral side reactions. It means it mainly increases the conversion from Lavadopa to dopamine in the peripheral tissue, so further increase the peripheral side reactions. And just now I also mentioned phenothiazide. This drug can block dopamine receptor in CNS. It can antagonize the curative effects by Lavadopa. So these other drugs, including phenothiazide and the butyrophenols, they are the agents to induce iatrogenic PD. This is secondary PD. In the treatment of this secondary PD, Lavadopa is invalid. When the Lavadopa is used in combination with some antidepressant agents, orthostatic hypotension, it is readily occur. Also need to pay more attention to this. Okay? Now, I mainly introduced Lavadopa and carbidopa. Of course, in the treatment of PD, this is the representative drug, and these two preparations are more important. But how about the other anti-Parkinson drugs? What are the characteristics of them? Let's go on. Lavadopa in the treatment of PD, it is very limited. So we'll have some other synergies of Lavadopa, including ADC inhibitor carbidopa. Just now I explained. MAOB inhibitor silazolin. Dopamine in the body, it can be metabolized by MAOB or C1P. These two enzymes inhibitors can inhibit the velocity of metabolism of dopamine. So they also can increase the function of dopamine. Neuroprotective agents can inhibit superoxide ion and hydroxyl radical formation. Silazolin work as an antioxidator. It can delay neurodegeneration and development of PD. There is a radical oxidative stress. That theory partly explained this disease mechanism. So this silazolin, it is relatively better than the other synergists of Lavadopa. Anti-cupping inhibits this COMP and then also can delay the metabolism of dopamine. Other drugs like bromocriptine. Bromocriptine, it is semi-synthesis of ergot alkaloid. This drug can activate dopamine 2 receptor of pituitary gland. So after using this bromocriptine, it can decrease the prolactin and growth hormone release. It also can activate dopamine 2 receptor of substantial nigra strata. So it can improve improve the symptoms of PD. But it has also more adverse effects related to that of Lavadopa. So it is similar to Lavadopa because it can decrease the release of prolactin and growth hormone. So it also used to treat lactating monostasia syndrome, PD, and acromegalia. acromegaly. This disease is related to growth hormone. Mandating. This drug in the treatment of PD because it can promote Lavadopa to enter into cerebral circulation. It also can promote dopamine synthesis and release from dopaminergic neurons. And it also can decrease the dopamine reuptake. For the inactivation process, it also is useful. So because of these mechanisms of anti-Parkinsonia, mandating is effective in the treatment of PD. But actually, this drug also is one antiviral agent. When you study antiviral drugs, you will study this drug again. When it is used in combination with Lavadopa, so it can increase therapeutic effects. In the clinical practice, the curative effects usually mandating is not as good as Lavadopa, but is better than that of anticholine drugs. Anticholinergic blocking drugs. These drugs, because of the disease with PD, this PD is related to the imbalance between the dopamine and acetylcholine neural pathways. So excitatory cholinergic neurons also participate in this interaction between structure in the basal ganglia. In PD, the degeneration of inhibitory dopaminergic neuron lead to a relative exercise of cholinergic activity in this pathway. So for this reason, patients with PD can be treated effectively with drugs that inhibit cholinergic activity or drugs that increase dopamine levels in the basal ganglia. So these cholinergic receptor blockers, they are also effective. But here, it is not atropine. Anticholinergic drugs and receptor antagonist, the representative drug is atropine. You have studied. But here, it is not atropine because the problem is in seeing eyes. Atropine has so many pharmacological effects on peripheral tissue. It just induces many adverse effects different from this trihexyphenidyl. This drug is also named by Anton and benzodiazole. It mainly acts on the seeing eyes, inhibit substantial negral corpus striatum pathway cholinergic nerve functions, act on the peripheral tissue. Its effect is very weak. It also can be administered orally. Absorption as well. Usually improve tremor. This therapeutic effect is relatively better than the others. So, used in combination with Lavadopa, Lavadopa to improve tremor, these symptoms is relatively weak. So it can increase the curative effect. And PD induced by phenothiazide, that secondary PD, it also effective because it can block M receptor in seeing eyes to recover the imbalance caused by phenothiazide. This is dopamine receptor blockers. It also effective to control that symptoms. In the next section, previous section, I introduced for the PD caused by phenothiazide, Lavadopa is invalid, but this one, anticholinergic drug, is effective. And the side reactions and contraindications similar to atropine. Although it mainly acts on the CNS, of course, it also can block M receptor in the peripheral tissue. just compared with atropine, is relatively weak. Okay, that's all for this chapter. There is a summary about this content. You know, the patients with PD, the problem is in substantial nigra stratum dopaminergic function. So increased muscular tension. So the patients with some static tremor, myotonia, bradykinesia, even ataxia. So because of this mechanism, you can understand the JAK mainly increase dopaminergic function, especially Lavadopa, and it used in combination with carbidopa. Try to understand why they used in combination. Do you know other drugs? Okay, review after class. I also give you several questions to help you to review. What are the drugs used for the treatment of PD? Why is Lavadopa used for PD combined with carbidopa? And describe the therapeutic and adverse effects of major anti-Parkinsonian drugs. You know, this major anti-Parkinsonian drugs means Lavadopa with carbidopa. So, do you still remember the adverse effect of Lavadopa? There are 5. GI tract reactions and the CVS reactions, you know, tachycardia, hypotension, nausea and vomit, and the CNS reactions include hyperkinesia, on-off response, or caused by fluctuation, and behavior effects. Okay, now this is the JAKs in this chapter you have studied. And this table also is an abbreviation, the summary about these chapters. Okay, that's all for this chapter.